It's nice to see you, everybody. Welcome to the Oceana Room. This is People, Not Patients, Human-Centered Universal Health Coverage. I am going to do a live experiment. If you're watching online, you can do this experiment later with your friends and colleagues. If you're actually in the room, here's a live experiment. Say hello to somebody in the room that you do not know. Have that conversation right now. I'm giving you 20 seconds. No cheating. Well, I am very impressed by the vibrancy of your hellos and greetings. I am curious, very curious, about what you said when you said hello to the stranger in the room. I'm just going to ask you very quickly. Changing microphones. Good morning. What did you say in your introduction?
So I just said my name and my country. They said the same, and we opened the conversation.
Where are you from? That's the biggest conversation starter, right, at the WHS. And what did you say when you introduced yourself to a complete stranger?
Yes, the first thing was, hello, how are you? And then after that, the response, yes, I'm fine, and how are you?
This is epic.
Then we started to now introduce ourselves properly.
I love that. So genteel. Good morning, sir. Did you introduce yourself to a complete stranger?
Yes, we did.
Okay, and?
Our names, where we're from, and where we work.
All right, the point of this exercise is nobody says, hello, I have hypertension. Did anyone say that? No. Did anyone say, hello, I have respiratory difficulties? Did anyone say that? No. Nobody introduced themselves using their NCD, did they? No. Because we're people, not patients, right? That is what today's conversation is about. Changing microphones. We would like to find out how robust universal health coverage is at tackling NCDs. What can we learn from NCDs? The good, the bad, the challenging, and how that can help with our mission for UHC. I would like you to meet your panelists. They have different areas of expertise. They're going to help us explore this entire conversation, this discussion, because, of course, one of the themes that we're looking at, our central themes at the World Health Summit, is recommitting to universal health coverage. And we're going to do that through the lens of NCDs. Omar, it is so nice to see you. Rahel, Bhagwan, Charity, that is my informal greeting to you, but you are going to tell our audience online and in this room who you are and why you're up here and they're back there. Omar, hello.
Hi, Femi. It's great to see you. Great to be here with you, all of you. My name is Omar Abdi. I'm Deputy Executive Director for programs at UNICEF. I've been with UNICEF for 31 years and worked mostly in the field in a number of countries.
Did you start when you were 10, Omar? There's no answer to that. Rahel, hello.
Hello. Hi, everyone. My name is Rahel Valletta, and from Ethiopia. I work for the Clinton Health Access Initiative as the country director. A pleasure meeting you all.
Bhagwan.
Hello, everyone. I am Bhagwan Koirala. I'm a professor of surgery working in Nepal. I've done a lot of cardiac stuff. In the second half of my professional career, I realized that just fixing hearts and operating is not enough to help people. I've learned through my professional leadership and working slowly into more of an NCD prevention control programs in Nepal, together with the Ministry of Health. I also am the chair of Kathmandu Institute of Child Health, which is the implementing partner for this UNICEF-led NCD, childhood and adolescent NCD program in Nepal.
Good to have you, Bhagwan. And Charity, hello.
Hello, my name is Charity Muturi. I have lived experience with a mental health condition and care for parents with 8 non-communicable diseases. I serve in the Global Advisory Committee, NCD Alliance, who I am representing today. Most of all, I'm a lived experience champion, and I thank you for including our voices here. It means that we matter. Thank you.
Absolutely. And my name is Femi Oke. I'm your moderator for the next 90 minutes or so. Thank you very much for spending time with us today. And this discussion is brought to you by the Helmsley Charity Trust. And now we can continue because I gave you an assignment. And your assignment was to make sure you bring a story, each panelist, that emphasizes where we are with NCDs, how they can help universal health coverage. Bhagwan, what was your story? What is your story?
Well, I, as a physician, clinician, busy practitioner, I have thousands and thousands of stories. Working in Kathmandu and trying to help people through simple treatment or sometimes very complicated surgical procedures. When they go back for follow-up, they just don't have place to go back in their communities. And for simple tests like PTINR test for anticoagulation measurement, or say for early diagnosis of rheumatic heart disease, which could be either prevented or treated with less complications, now have all sorts of tons of problem, putting them into poverty line, below the poverty line, or forcing them to come back to Kathmandu for simple follow-ups. And those stories are endless. And that kind of always pushed me into thinking, what can we do to make those so-called secondary level of care available at the district level so that they don't have to come back to Kathmandu for follow-ups, or in the first place, to make those services available right there closer to the homes so that they don't have to actually travel to long distances. Even if those services are made free in Kathmandu, it doesn't really help because they just don't have a lot of resources to travel and pay for themselves. So it's a suffering of our own in a way. Trying to do good, we found new sets of problems, and that's why I'm into this.
Bhagwan, your conversation inspired Charity to write notes. I have no idea how you could inspire her so quickly, but Charity, what did you write down?
I wrote down that my story is that I believe that when health systems fail us, we die. We bury our loved ones. And as a result, it means that where every health decision is made, we need to be at the table because we pay the highest price. And so I believe in nothing for us without us. So I had the pleasure to serve in the National Task Force on Mental Health in Kenya, currently as a court petitioner to decriminalize suicide attempt in Kenya, and also in the Ministry of Health, Quality Rights for Mental Health Training team, because I believe in being part of the process of creating change and making decisions.
Well, I'm thinking about the work that you do with UNICEF because we have Charity from Kenya, we have Bhagwan from Nepal, we have Rahel from Ethiopia, and you kind of represent the world in a sense. So the work that UNICEF does with young people, children, and NCDs, what can we learn from that as we head towards universal health coverage?
Yeah, it's interesting, Femi, that you ask, because usually when we talk about NCD, we think about adults, right? And most of the programs actually are geared towards adults. But let me share with you a personal story. I grew up in Somalia, a small town in the southern part of Somalia. And when I was in grade 4, a classmate and a friend was diagnosed with diabetes. We didn't know what diabetes was even then, and she was losing weight. But in a year or so, she passed away, unfortunately. Now, the second time that I came across again juvenile diabetes is when my daughter at age 7 was diagnosed with diabetes as well. But fortunately, she was born in Canada. This is the inequity that exists there. She was 7 then. She's now 30. She Her life is normal. She wears a pump, glucose monitoring on her shoulder. Her phone tells her when she has to eat or her sugar is going up. So you could see it, the inequity there. Just the accident of where you are born, you either live or you die because of a disease that is treatable or manageable. So that's why UNICEF focuses now, and I'm glad to see Stefan here, our former chief of health, who's one of the people who emphasized that we should double down on NCDs and children.
I just wanted to follow with Omar, exactly the disparity that we have in developed and in less developed countries. If you take Ethiopia now, for example, I was wondering, all the three of us have become neighbors. So, more than 58% doesn't know even they have diabetics. As we speak, this is a huge disparity. If you don't diagnose, how do you treat? And access to diagnostics, especially as you go further to the rural areas, you won't even get it. So that's also another thing. When we think of universal health coverage in 2013, today we are in 2023, almost finishing. So how is it we are going to catch up within 6 years, to diagnose more than 50% of the population? So that is the real need and the call for action as I think of.
That question, how is it that we can catch up? Is that just a question that you're just throwing out there, or a lament, or a challenge? What is that question saying?
That question says, yes, we do have a lot of challenges, but at the same time, there is also an opportunities that we can think of, because we are seeing primary health care as a vehicle to universal health coverage. And especially now in a country like Ethiopia, where we have a strong health extension workers or grassroots communities, if we avail them the right tool to diagnose, they are there to help. And this is not new. We have proven in many other aspects. I can give an example. In a country where, 10 years back or 20 years back, skill delivery can be 6%. Now we are almost 64%. So you can see how far we can jump, even in a limited resource setting, if we get the tools to move us forward.
This idea of catching up and addressing NCDs, it's something that is encapsulated in the PEN Plus program initiative. And it's not just shrugging our shoulders, what can we do? There's an actual policy, a program. Can you tell us how it works in Nepal?
This is a great question. To begin with, we should recognize that poor countries also have massive burden of non-communicable disease in children as well as in adults. And now the numbers are terrifying if you can go back to those numbers. Almost 3/4 of deaths in Nepal are due to NCDs. If we add trauma, it becomes even more, kind of plus 8%. Now, many of them are either starting in childhood, or some of them are very specific to the childhood NCDs. That was one of the reasons. And one more point is, if you fix them, prevent them or fix them as child, these kids have huge opportunity for lifetime to contribute to the society and the world in general. And I've seen thousands of those kids being fixed at low cost and have contributed to the world economy, I believe. And I'm lucky to be part of that process in small way. Now, this was the academic discussion primarily generated from the Lancet Commission, reframing the care for the poorest billion of the world. It kind of gradually evolved into NCDI Poverty Network, and then we got along with them to try and copy that in the Nepalese context. What is happening today in Nepal is we have this prioritized disease conditions of NCDs focusing on children and adolescents. We drafted the priority settings together with the Harvard group. And now that has been owned by the Ministry of Health as part of their a program at the district hospitals as a pilot as yet, 6 districts out of 77. But I think it's working out well. We're just launching the clinic now. We can see there were so many missed diagnoses before. Either people didn't show up at all because they didn't know, there were no facilities, or they were not being able to diagnose because they were not trained. The human resources at the districts were not trained. Now that we can see the difference of picking them up early at the district level, sending them for follow-up at the district level. I think that in itself is already showing up as a very promising project now. So diagnosis and treatment, early treatment of very equitable disease condition like sickle cell disease, the early detection of rheumatic heart disease that can be prevented or fixed, congenital heart diseases, and so many other type 1 diabetes, which could be treated and then made the children functional. So all of that is part of the Pen Plus projects now happening. The care being delivered through the district hospitals. We've got a long way to go, but I think it's a very promising initiative. And I must tell you that this is very logical. I mean, we don't have to criticize or downplay the value of primary health care. Appreciating that at the highest level, you have to get on to the second level. Otherwise, how do you complete the continuum of care from the basic primary level to our tertiary care in Kathmandu or wherever in the country is? So unless we have this secondary level of care going from primary and then holding them up in the district so that they don't burden the center at the same time the care is at the neighborhood, I think that really gives a chance to close the loop of continuum of care at all levels. I'm really glad that we're trying to do this and see the results in the next several years.
Bhagwan, what percentage of our audience in this room do you think already know about Pen Plus?
Well, I hope 70% at least.
All right. Show of hands if you've already heard of Pen Plus. Ooh, what is that percent? 0.5%?
No, more than that.
More than that?
Yeah.
Okay. So
or at least after the session, 100%,
some shy people
100% would
know.
know this after the session for sure.
All right.
And I can tell you this is very powerful in my view. Myself being a clinician, I know this is very important for the countries, including the poor ones.
All right, so if you could explain Pen Plus in a sentence, and then we can get into this in the Q&A as well. If you want to ask more detailed questions, please do.
You want me to do that?
Yeah,
Great.
very quickly.
Now, most countries, less developed countries, have this WHO-led PEN packages, 4x4, prevention treatment of major NCDs. Just basic stuff, treatment of hypertension and diabetes and respiratory conditions, one medicine each, and then counseling. I mean, it's logical to say that that's not enough if we really want to march towards the universal health coverage. There's so many other problems, more complicated, wider range of disease conditions that are plaguing our society. So that's Pen Plus. The growth from Pen, the basic 4x4 model, getting into little more diverse conditions like sickle cell, rheumatic heart disease, congenital heart disease, type 1 diabetes, and also included the Pen conditions, and then go into a little bit of a depth in terms of diagnosing and being able to treat them at the district hospital level. That's Pen Plus.
Omar, I think you have a question, or would you articulate the note that you wrote down?
But I think the prevention aspect that the professor talked about is very key. And looking at this holistically, I mean, from the food systems, the whole environment that a child grows, I think is very key. And NCD, of course, lifestyle is very critical as well. So I think in terms of prevention, knowledge, I mean, a lot of people don't know how they can prevent some of these diseases. I think behavioral change. And so I think in addition to, of course, the treatment, which is critical, and the diagnostics, the role that technology now can play in terms of point of care diagnostics, I think there are more opportunities today than the time when my friend was diagnosed with diabetes.
There is a thread between Charity and Bhagwan in the way that you approach your work. Bhagwan, I know that you've used patient advocacy, patient stories to inform your work. And Charity, you are a patient's advocate. Can you tell us about that journey of how you went from a patient to an advocate to a speaker at the World Health Summit? and many other summits around the world?
Okay. When I was diagnosed with mental illness, and that is in 2015, Act 35, and we looked and saw this started when, 20 years earlier. I had a process of understanding myself and so on. And in the process, I met many other people with mental illness in support groups and so on. And in the process, I stopped being a private patient and started using public services. And then I became passionate about raising my voice to speak about the, access of essential drugs, drugs without adverse side effects, and even better infrastructure, better social health insurance, better social protection. And so when the National Task Force on Mental Health was formed, I had people living with mental illness around me asking, why aren't we on the table? But, they had different reasons. My doctor is in the task force, or I work for government, and I had nothing to lose, or so I thought. And so I, fought. I started saying, nothing for us without us. And I had an opportunity to serve in the task force. And after that, we continued to push for more seats. And so far, we've had persons with lived experience with mental health conditions in 8 national health boards. During that time, I met the NCD Alliance Kenya, who introduced me to NCD Alliance Global, and we started running with that, nothing for us without us. So through the process, we were able to work with WHO and a team of 50 patients across the country to develop the Nothing for Us Without Us publication, which basically talks about the meaningful engagement of people living with NCDs, and this is with the NCD Alliance and WHO. And then later, we started looking at some of the challenges that we have. So we are doing advocacy, we are doing policy, but usually we are the only unpaid people in the room, or the only unemployed people in the room. And so we together developed a framework, the WHO framework of the meaningful engagement of people living with NCDs. And so we looked at matters of remuneration, capacity building that we need in rights and policy and economic empowerment and things like that. And we also developed the NCD Alliance Global Charter of the meaningful engagement of people living with NCDs and mental health conditions to guide governments, multilaterals, civil society, academia and research on how to engage us, because we know that it is important, and it's easier for us to say this is how you can engage us. So that has been my journey so far, and it's been a very fulfilling experience.
I like the way you break it down. It's how to engage us. So whatever field you are in medicine, you always have to interact with people. So how do the medical profession interact and engage people who need their help?
There's an opportunity in policy and practice. Our first fight has been to be engaged in policy. And the most practical way is to be included in committees on health and to make it mandatory that our inclusion should be there. Because I usually say that the doctor sees 180%. I see the other 180 that then makes it a 360. And Professor Lukoya Toli is here, one of the people I really admire in the leaders of psychiatry in mental health. And one of the things that I've discussed with doctors is that no, 500 Kenya shillings is not what it costs for therapy. There's another 500 for me to get to the center. I mean, unless you bring it to my house, then it's 500. And so we are able to look at what are those barriers that we have from our perspective. The second, so in policy, like I said, we've gotten 8 seats. And our first regional one in Kenya, we have counties. Because health is devolved, and we've managed to get 1 seat in that. But beyond that, being able to go to practice, because sometimes we help to set the strategy, but it won't necessarily be implemented the way we would. So now we are pushing, like at our National Psychiatric Facility, to have a patient affairs department, so that we move into implementation, monitoring, and evaluation, because we are saying nothing for us without us throughout the continuum of health.
Does that Really happy, like, sure, Charity, come in here, NCD Alliance, where have you been? We're so happy to see you. You're making it sound very straightforward and simple. 1 step, 2 steps, 3 steps. How is it really?
It comes with challenges because, when we are at the NCD Alliance, at the our Visa Voices Advocacy Committee, it's very easy because we think the same. At NCD Alliance, we think the same. But one thing I have to give credit to our government is that the Ministry of Health has really embraced the issue of inclusion. The reason I have an opportunity to speak today is because our Ministry of Health has been receptive. So when we pushed for the task force, 2 months had gone already, but we were able to come in immediately. What I've realized is that other countries in Africa and other countries in the world are still talking about having a seat at the table, but not doing it. So it sounds easy when I say it because our government has enabled it. But the other thing is, sorry, I need to take a sip. Sorry. The other thing is when we are fighting for these policies, our culture also has an issue around it because legally there's this issue of unsound mind that many people do not understand, and they feel that people with mental illness do not have capacity to sit anywhere. And so by our Ministry of Health actually allowing us to sit in those seats, we've been able to give examples to other countries. So this is a call to action to other countries to embrace us as persons with lived experience, as civil society, to actually work together and begin to walk the talk. I think we've talked about it quite a bit, but we need to start walking the talk. So it is possible. It may not be easy. It will be different in different countries and different continents, but it is possible.
Reha, I want to talk about the work of the Clinton Health Access Initiative, because one of the things you're dealing with is financing to get the best universal health coverage that you can possibly get. But again, that word that will keep coming up in this conversation is challenges. Tell us about that work.
Yeah, especially now, financing is becoming more and more interesting. I think people really want to hear more about it because it is not only resource coming, from outside for implementation, but we have to look internally to raise resources, even if with the little money that we have. And I agree with Bhagwan, especially now, our countries are facing, it's not only non-communicable diseases. We have communicable diseases still. And with the climate change now, we are seeing even diseases which has been eradicated coming back. There are some issues that we are seeing. Trauma, mental health, all those things are really becoming, a burden to the countries. But at the same time, the role of international organizations or the role of, resource coming from outside is really changing because more and more countries need to engage and raise resources. Of course, we talk about the Abuja Declaration. In most cases, when we talk about resource, that's a small amount. For me, rather than seeing that, which percent we have reached, it's the commitment that we have started. For example, if we take Ethiopia, we have what we call community health insurance program, which we mobilize more than 12 million households, which is about 58 million of the population. Actually, this can be a country by itself. In other countries are being rolled into this community health insurance. But that doesn't mean that the community health insurance is going to address all the need that we have. Because first, the amount of money, the contribution which is coming from the community is very little. The second aspect of it, which we are also facing a challenge, is commodities. When we talk about local manufacturing in here, I think these are some of the things which we really need to advocate and see, because if we see the cost breakdown of the commodities that we are getting from outside, literally 40, depending on the countries where we are, the margin goes with the supply chain, the middleman in between. So taking out that into consideration, that's also another resource that we can bring in. The other aspect of it is efficiency. With the amount that we will be getting, how are we going to utilize that money? Where is that money going? Is it actually for the intended purpose? So there are a lot of pieces that we see, and GHI is supporting the government in this aspect, including resource mapping, efficiency, in all aspects, we are doing quite a lot. And these are the work that we are seeing. Now, the community health insurance, for example, currently the way how it is organized is more of a community-based. They are not being aggregated or brought together. So now what we are helping and trying to support is how do you bring in all those money together? Because in a country where we have those region, ethnic diversities and all, so there is a lot of political discussions and something that we need to be doing to bring health, a common good than, a political agenda. So that are some of the effect and some of the work.
Yes, Omar, go ahead.
I think the issue of financing, first of all, we're advocating that governments allocate more to primary health care, especially community health. The investment return, according to the World Bank, is 10-1. Each dollar invested in community health, the return is 10. But more importantly, also, we are advocating for partners, external partners, to align their funding to one national plan, one national budget, instead of each partner pulling in one direction or the other. And I think tomorrow we are going to launch a community health delivery partnership, where a number of partners, WHO, UNICEF, the bank, Global Fund, and others as well, Gavi, GFF, all coming together and agreeing that for those governments that are going to develop their national plan for primary health care and provide investment in there, that we will align with that one plan and one budget and one approach and require one sort of framework, results framework. So what we have heard this morning in a previous session that I was on, that community health workers are spending more time filling out forms and papers rather than treating things. It's because each partner requires certain indicators to be reported to them in a certain way. So we're trying to align and have only one framework for all of us.
Dr. Bhagwan, you were smiling when the forms were mentioned. How many forms are you involved with?
Well, that's double-edged sword. Without forms, without data, you can't really generate an evidence and convince the policymakers, as well as you be yourself informed. At the same time, it takes really long time. So it's again the way you devise the forms and data keeping system to make it more efficient, less time consuming for clinicians or the healthcare workers, so that you capture the data at the same time, you save more time for patients one-to-one. And I just wanted to, follow up on Charity's comment. I was thinking while you were talking, one of the reasons that I was excited to come to Berlin, apart from the real reason of this this event, was Charité. Right? This is Charité where Rudolf Virchow worked, and I learned a lot of things in terms of the qualities of a physician. He, 100 years ago, Rudolf Virchow wrote us, and we followed, is the physicians are the most natural ally of the poor and the sick, and we need to advocate for the poor and the sick. And the principle of advocating for the root cause of disease by being a physician is something that I really learned from those historical readings. And I really can read, we have this big hall named Rudolf, but Charité is right next door. And that's the kind of context that I was trying to think about. Coming back to the point, we advocate for the real causes of disease, root cause of the disease, the social determinants and all that, part of our duty. But more powerful than that is the people speaking for the cause themselves, from the benefits that they get from the programs and the results that they come out. And even more powerful probably now that we have to take into consideration is the patients' advocates, because they are the most dedicated team of people who can put the agenda because they've suffered through, they've gotten the result. They are the evidences themselves to be able to talk to the policymakers. And this is very contextual that we're taking that up as a very important way of advocating for the new program, new agenda, in health agenda, trying to go to universal health coverage. I'm really glad that we're together on this. And that we, in the Pen Plus project, right from the beginning, we have a dedicated people who are patient advocates. Actually, they go to different international meetings and trying to
How do you find them? Where do you get them from? Charity, you can take over. You can be moderator now.
Okay.
For the next 5 minutes.
No.
Because this is your territory.
Yes.
Go
yes.
ahead.
I'd like to just acknowledge the issue of root causes, because I think health tends to be very reactive, and we talk about prevention, but we don't quite do it. And when I look at the root causes of mental health conditions and NCDs, very, very similar in terms of poverty, unemployment, gender-based violence, conflicts, and so on. And we do need to put a lot of money in that, which echoes also what Mr. Abdi has talked about in terms of finances. In terms of people, this is people, not patients today. In terms of us as people living with NCDs, one thing that I have learned through my journey is that we accomplish more together. Actually, people in the mental health space feel like I'm not loyal to them because I push for both mental health and NCDs. And this is one example. Like for mental health, for example, has, for the longest time, until recently, gotten 0.01% of the health budget. But when I learned that all non-communicable diseases, everything that's not HIV, COVID, malaria, and TB, we all get 3%. Then it changed my perspective. So now we push for mental health to be increased and push for NCDs, because we can't have mental health increased and removed from cancer in terms of budget, you know? So I think my biggest learning has been that as much as I have my experience and I have other people's experience, us pushing together helps. And that is, you know, as persons with lived experience, but also as caregivers. The other thing I wanted to say is that it's one thing for us to want to be included, but it's another for people to actually commit to it. And one of the ways we have to do that as the NCD Alliance is the Global Charter of our Meaningful Engagement. And I'd like to encourage everyone here to log in online and look for the Global Charter and actually endorse, because that gives us credibility. It moves us from speaking to actually talking. And also to say that everyone in this room should make a commitment to include us meaningfully, you know? And for me, meaningful engagement is leadership. You know, when you see someone on a wheelchair in a photo of parliament, it speaks more volumes, you know, than having a long press statement or something like that. And so even having us as persons with mental health conditions who are looked down upon, especially in low and middle income countries, in places like this, it speaks volumes. So let us move from speaking and do. Ask yourself, as John, as Zachary, as Rachel, what have I done to include people with lived experience in my work, in every way? I sit in the Monitoring and Ethics Committee of the King's College London research on postpartum depression in Lebanon and Kenya. And that gives me a lot of, I don't know what to call it, agency. Yeah, even being in the OVOV, because I do not have a degree. I have failed to have positions and opportunities because of the lack of that degree. But when you put me in a place where you say that what I have to say matters, even when I do not have a degree, that when, you know, caring for 8 non-communicable diseases in the family and for myself is experience, then that means a lot. During the session on UHC, the previous session, I had a question for academia and research, because yes, we are coming up as lived experience and we are saying that our value is enough, but it would also help to have incubator programs for us in academic programs that would say, okay, based on your experience, we can give you an honorary degree or capacity builders. Yes, thank you.
Charity, ask Bhagwan a question because he's talked about the patient advocacy that he encourages and supports in Nepal. What is the most provocative question you can ask him about how he's doing that?
I would ask, or I will ask, I will ask, have you asked these people with lived experience what they need? Because most times, most people who come to me have already decided what I need.
To be honest, I probably would not be giving you the most satisfying answer here. We do work with them, as I said before. We're working on the challenges they face, not just the financial, not just the technical, but keeping them in the forefront of policy drafting or the discussions of some of those things. I think we still need to learn a lot from you. Thank you for raising that.
I like that this session is called Human-Centered Design, because I think many people come to us when they've already decided what we want or they've already put a proposal together. But co-creating really means coming and asking us, what do you need? Yeah, before you have already determined what you want to do. Shadow our user journeys, Even just my journey to this conference would have taught people a lot of things. So allowing us to, be with you and you spend time with us to understand what this means for us on a daily basis in accessing care, but also in advocacy and policy.
Rahel, you're the only panelist who hasn't told us your story, and you're not escaping the assignment. Please go ahead.
I think when I think of NCD, I don't think of them as a far away things. Nowadays, if I look my mom, that gives me a reminder on a constant basis what I need to be doing. If I see my uncles, exactly I need to do something. My neighbors, those people who have been, show me, guide me to this life. So it is not something that is far away. And what makes my heart ache is also not reaching for them early. Like the way how life really becomes, complex and complicated for them because we don't have the pathway, for care. If you don't diagnose it early, the complication hits. And when the complication hits, first of all, our medical setup is not there to support us. Even if there is a medical setup that we can take them there, the cost is really, exorbitant, and it's very challenging for the family to hold. So it is not something that we see it from far away. This is knocking every day, and that is something that really keeps me, to push even further.
I am going to push you panelists to start thinking about the impact your work is having in the NCD field, how that is being reflected in universal health coverage, or how it could be reflected. So I'm going to start thinking about impact. Rahel.
I think one thing which I'm seeing, as a major impact when we are looking into the patient at the person as the center. My mom goes to the facilities, to do a checkup. Is she getting, a whole-rounded checkup, or is she actually being asked to move from one side to another side? That is another area where I think we can bring in an impact, and that is how, as GHI, we are trying to integrate things, or see what would be the opportunities, the best way to integrate things. Like, if a person comes in for one taste, can they get for 2-3 things. Like, for example, in a clinic where you go for, HIV checkup, can you get it also for syphilis or for other things? A combined services within a facility. That's how, impact can come in. The little resource that we have, we can use it more wisely. And the other aspect is the early information and the early education that we really requires in our setup. Because this is not something which has been known or been kept, like in our setup, like when I grow up, it is only one person that I know all my life who has diabetes. So we used to call it it's a rich man's sickness. It is not even associated, but nobody knows that it is actually, within us, among us. So, when we talk about impact, it is not something that we need to look after some time, which we really need to see what can be done today and now. Those are the things which we really need to bring in. It is not about, repurposing even whatever we have. The way how it has been said, because primary health setup is there. That how do we make sure that we use the primary health setups to inform or to help us screen those who are in need early, so that they're along the continuum of care will be supported. How is the referral linkage is going to be? Because currently we talk about drugs, but the drugs are not affordable. How do we bring in public-private partnership to ensure that those drugs are actually accessible, affordable to the majority of the people that we have? Because as we speak, over 31% of the general expenditure of health is out of pocket. With this economic challenges, with this inflation that we are all facing, is that going to be an affordable way of moving forward? By all means, it is not. So we really need to see some of the things, and I can cite an example. For example, when GHI started, the Clinton Health Access Initiative started working, which is an HIV organization. During that time, drugs for HIV patients were quite expensive. It's more than $300 US per 1 year, and which majority of the population will not afford. But currently, it is about $45-50 per year course. So you can see that if we work together, there is an opportunity. This doesn't mean that our manufacturers are going on bankruptcy. No, they are still making profit. It's the way how the marketing setup has been changed. It's the way how we start up, the approach that we brought for them is different, because now we are going collectively rather than going bilateral, individually. Even here, we really need to come together and approach them. And there is willingness also from the private sector. So I think to create an impact, we need everybody, like people who are facing the challenges, the health professionals, the government, the community, like international organization, bilateral organization, local NGOs. All of us need to work together to create that path in addressing it. So for me, I feel once we do that, we will get the real change and impact from what we will be doing.
Omar, tell me about UNICEF's work with NCDs and children and the impact that you are having.
First of all, the numbers are still horrific. There are about 1 million children and young people under 20 that die every year as a result of NCDs. I think as Rahel said, and there are a number of issues. One, and they all surround, on access to information and knowledge. A lot of NCDs can be prevented if people have the knowledge and access to the information to do it. The access to the diagnostics that we've talked about. There are innovations now that A lot of diseases can be diagnosed easily at point of care, but the developing countries have access to those tools. And then, of course, the treatment. Yes, there are some medications now, like the HIV, that are affordable. But there are a lot of other drugs that treat NCDs that are not affordable in developing countries. I think a similar approach as the HIV/AIDS kind of one. We need that sort of movement to be able to, the new drugs and medications that are coming out to treat a number of cancers or mental health and others become also accessible to developing countries. And I think, and we're seeing that movement. I mean, we didn't have NCD discussions in forums like this, so at least this is good stuff.
What's your biggest challenge? What's, if you had the resources, would you fix immediately?
I think it's the act. I mean, for example, we're working now with Eli Lilly and others to get insulin to some of these places. I mean, just kids die for type 1 diabetes because they don't have access to insulin. We were having a session with Siemens Healthineers today discussing about making diagnostics available at those. So it's availability of these basic medications that are taken for granted in developed countries, which are not available.
Charity, impact, that is the whole reason to be a patient advocate, right? Impact.
That is true. People, which is central to this conversation, because I go to a different hospital for my mental health condition. My father goes to a different hospital for his heart and other issues. My mother goes to others. And so for me, being able to speak until we are able to have a one-stop shop, because my desire would be that the clinic that is closest to us would be able to address all our needs, so that I just have to move from caregiver seat to patient seat, but not transverse the country for different services. So impact for me is what we are doing right now, pushing for things to be done. And also to say we need investment in mental health and for NCDs as well. We can't keep talking about it. We can't be at 3% of the health budget after all the noise that we have made. So impact is making it happen. But also integrating mental health in NCD management and chronic care management, really, because I see how the illnesses my parents have affect their mental health. And so we shouldn't integrate mental health in all care, because I think we did a study with, I think Professor Tolley was included in seeing that 40% of inpatients in hospitals have mental health conditions, and so we should integrate that. But also to say that integrating NCDs in UHC packages as a very key area and making it rights-based. Last week we had the World Mental Health Day, and the theme was or is human rights mental health is a basic human rights. And one of the reasons why I've been successful in advocacy so far has been because of engaging rights-based. I remember even when I joined the task force and I was just so scared of speaking, there are these 3 lawyers and human rights advocates who formed a WhatsApp group, and they told me, whatever you need to say, tell us and we'll help you say it in rights language. So they taught me that the government does not listen to needs, it listens to rights. And that means being able to speak in a rights-based way. And so that's part of the capacity building that we need. But also to say inclusion should be mandatory. Our inclusion should be mandatory, whether it is at national level, continental level, global level. My desire is that every WHO country office would have a lived experience desk ask, so that if I go there, I speak to someone like me first, and that every civil society here and academia research would have representatives of our own, not as tokenism, but in the leadership of programs. And I know we keep talking about everyone having, someone with NCDs, but I just want to ask if you would allow me, if everyone would lift their hand, if I mention an NCD and you or someone in your family has that NCD. Diabetes, cancer, hypertension, mental health conditions. Don't put it down, just keep it up. Diabetes, cancer, hypertension, renal issues. I think our hands are all up. So say with me, nothing for us without us. Louder, nothing for us without us. Thank you.
Bhagwan.
Is there anything left to speak after?
There is nothing left. I tell you what I will do though, for the audience, now that you're warmed up, Charity, thank you. This is your 4-minute warning that I am going to come amongst you so that we can reverse where the conversation happens. You've been so patiently and leaning into the conversation, and we want to lean into your conversation. So I will be out there with you. Don't worry, there's no camera, so we can just talk. And then you can talk to our panelists and with each other. So that is your 5-minute warning for that. If you have thoughts, comments, questions, don't be shy. We're all friends. We all know each other because nothing without us, about us, or nothing about us without us. There's something also that I learned, which I love. He or she who wears the shoe knows where it pinches the most, right? And you're like, you can visualize that. You're like, oh, that hurts. Only the person in the shoe knows how much it hurts. Or it's comfortable. Only the person in the shoe knows it's comfortable. So I'm adding that one on to your chant, if that's okay. Bhagwan, okay, I've stored enough. Impact that you're making, that your work is making.
Well, that's the tough question, because if we could prove in numbers, this is the impact, this many lives we can save, this many morbidities and sufferings we could save, it would be a lot easier to convince our policymakers. But I know for sure, over the next 5, 7, 10 years, after the initiative of strengthening the district hospitals for secondary care, there will be less suffering of people, less people will die, less children will suffer. That's for sure. Again, we need to have those forms and data kept up to date so that we can say that in next 5, 10 years. And I think the whole mission of our medical science, our public health, is to reduce the suffering of people and reduce the premature deaths. I'm totally convinced that's going to happen. One more word about universal health coverage. Remember that I'm a late learner of public health, but if you just think of that cubicle, unless you expand on the ranges of conditions, increase the complexity, and reduce the cost burden on people, how do we improve on universal health coverage? I don't understand anything else. So I'm totally convinced that's the right way to go.
All right, great. Delegates, now over to you. Thank you so much. I love this summit. I don't have to beg anyone.
Hi, I'm Stefan Peterson, Karolinska Institute at the Makerere University. I'm a product of the food environment, the physical environment, and the social environment in which I live, and I don't make many choices myself. And what's the risk you see of actually individualizing this? Choose wisely, little friend, else you'll go sick. When in fact, in the food environment, what we eat is a product of the commercial determinants. So how much should we actually be working at societal level and changing the food, physical, and social environments to do effective prevention and not blaming the individual?
Thoughtful faces. Omar, thank you for volunteering.
It's important when a physician is asking that question. I think we're learning more, and unless we look all of these issues comprehensively, and I think Charity alluded to that as well. I mean, mental health is determined by a lot of things, right, surrounding the individual. I think it's the same thing. So that's why I think we need our advocacy to continue to what we eat, what the food industry produces. I think we've done well in advocating against breast milk substitutes. But I think all of these sugary drinks that are there and all of the other unhealthy foods that are being produced, I think the ultra-processed food that Stefan is referring to, I think are all critical. And I think we should hold industry accountable for what they put on our table.
May I add a sentence to that? I think that's a perfect question. And that's why we said, it's so important to have health in all policies. A lot of things that are under control of your own individual behavior, but a lot of things are not in our control. And I could add one more point, like the urban pollutions now, which is people don't have a control over now. What am I going to do? My city is bad. That's where the policymakers and politicians have to act, and that's where the role of a bigger level leadership comes in. That's why health is also politics. There's a lot to do for the politicians and the policymakers, so I think it has to come together hand in hand.
Hi, my name is Mustafa Kamala. I'm a junior doctor and also communication specialist from Kurdistan, Iraq. So during my rotations and during my work in the hospital and in the emergency department, I've seen many people that come with late complications of their NCDs, not always necessarily due to lack of resources or accessibility, but also to lack of awareness and lack of knowledge on their NCDs. And as we know, a lot of these NCDs could be asymptomatic and could be much easier to control during earlier stages and much more expensive and much more difficult to control during later stages. So my question is, what solid work also has been done to invest in awareness, in sharing awareness, and to invest in sharing knowledge about these common NCDs that I think a lot of us or a lot of our close people are dealing with. Thank you.
Rahel, you want to take it?
Right. I think that's a right question. Yeah, that is why NCD is not on the spotlight so far. We talked about a lot on non-communicable diseases. That is where the efforts, majority, were happening when it comes to behavior change communication or all the other things that we were been doing. But now we are seeing it. The issues are becoming way beyond even the communicable diseases. It's not, it's the care, the continuum of care that we will be requiring is becoming even huge burdensome. And that is why we are saying that we need all of us to be, an educator, to be a communicator, and to help also pass the way for people to get the right treatment. Otherwise, it is something that which the world cannot afford it. I think that's one thing which we need to see, because it's not something that we will stop here, because the insurance that I was telling you, it treats the minor treatments, but once a dialysis hit, an insurance withdraw. So what does that mean for the family? So I think that is where we all need to work together to ensure to pass those informations, as we were talking about the dietary aspect as well. Thank you.
In terms of, it is helpful to also do awareness in unconventional means, because there's only so much the Ministry of Health can say in matters NCDs. As the NCD Alliance Kenya, especially after COVID, we were the first to do a virtual press statement. And it was us as persons with lived experience talking about the things we need, but we also included issues of nutrition and so on. And so as people are listening to the news, then they are able to hear that nutrition is important. But also, just like I shared in the previous session, Kenya is a very religious country, especially in matters mental health. And so at least once a month I go to a church, a mosque, a temple to speak about mental health, because in our country, they are viewed as these symptoms are viewed as witchcraft or demons, and that is a reality, And so you find when I speak in a church, there is more behavior change than even when I speak in a media opportunity. So I think we need to go beyond the influencers of health to our influencers socially and in other ways so that we're able to create that kind of change. Thank you.
Thanks. Hi, I'm a junior doctor from London. My name is Jake. Thanks. It's been really interesting discussion, very creatively moderated. Really enjoyed it. And it contrasts a bit to yesterday. I went to a session about where Pfizer and Gilead were talking about all the great, they effectively rewrote history in front of our eyes about how great they'd done in the pandemic. And I really enjoyed that we kind of touched on drug pricing. And my question really is about access to medicines and what we can learn from the last few decades of campaigning for access to medicines. We've touched on that, but how can we maybe apply licensing agreements to improve access to generic treatments for obesity? There's currently no obesity medications on the essential medicines list. And when MSF supported an application, it was rejected because of the cost, the price. But actually, these medications have been around for a long time as the same treatment for diabetes. They're being charged extortionately. So I wanted to just see if we can discuss that a little bit more about access to medicines and, yeah, thanks.
Who feels most qualified to do access to medicines? Rahel?
Yeah.
Okay, thanks.
I think when we talk about access to medicine, the first thing which I feel is we really need to demystify, manufacturer and the buyer. Yeah, we really need to be in the same table, and discuss and understand what it means, and then minimize the gaps that we will be having. Of course, private sectors are there to make a profit. It's not a charity organization, and we need them also to make a profit. But what we are asking is let that profit be reasonable, so that the communities also will benefit from the product that they are producing. But at the same time, if we are giving, because one of the things which they are putting, if the batch is little, the cost of production is expensive. So how are we, how far countries are also ready to bundle their procurement? Because that will give a guarantee for the manufacturers, to produce a product with lesser cost, for the community. So those are the other things also which we really need to see. But I feel, based on the experiences that, in regards to the GHI has done so far, not only on HIV, but for family planning, even with the insulin currently, there are discussions going on. It is possible. So for me, I feel, let's make them a partner and plan together. The way how we are saying that, it's a person, that we will be looking at. So even there with the manufacturing, there is a person, whom we can talk to, whom we can convince, and we can show how things can be done. And of course, the other aspect which we need to see is this transfer of knowledge, because one of the aspects that we were been seeing is, even if we produce it, in different location, the cost of transportation is also something. Sometimes that might not be the right one, because if the quantity is little, it might be better to produce it in, outside the country. But even in Africa, for example, if we are taking, how many of our countries are trading? Those are the questions which we really need to ask. It is not about the West and the other. Even among ourselves, we're not trading. Of course, there is now this Africa Free Trade Agreement. How many of us are actually trying to exploit that one? Because Ethiopia has its own manufacturing, Kenya has its own, Sudan has its own. What will be the leveraging factor that which we need to see? Which one makes sense? If we produce it in Ethiopia, then buy from, our neighbor Sudan for the rest of the products that we have. Or the other thing is, how do we make sure that the active ingredients, because that is something which is actually been kept at hold somewhere, how do we make sure that that will be, or the technology will be accessible to the others? So those are the additional things which we need to see, but I see it, partnership and working together will resolve the issue. So that's how I see it, rather than putting a distance. Let's bring them together and work together to address it.
Thank you very much. Allow me first to appreciate the panelists for sharing your experiences and journey with us. My name is Esther. I'm from Namibia. And thank you to Charity for bringing up the issue of mental health, something that I'm very passionate about. In fact, my professional background is social work, but I'm currently serving as the Deputy Minister of Health in Namibia. Now, you partly touch on what I wanted to ask, because especially in African Black communities, mental health is associated, is ascribed to witchcraft, angry ancestors, and so on. Now, the moment that the person is diagnosed with a mental health condition, already the family members will start deciding on behalf of that person. It's about him or her, without him or her, and deciding that the first stop should be the traditional healer. And they will even sell their cattle to take the person there, rather than approaching professional, service providers. So I just want to hear from your side, what is your experience, especially in this regard? And as an advocate, you mentioned you go to the churches, but what else do you do? How do you link up with traditional healers and families and communities for them to understand the whole issue of mental health? I thank you.
Okay. I can answer now? Yes. All right. Oh, yes. I thought we were taking another question.
Leaning into this.
Yes, one. Yes.
Right. Now, how is Charity going to explain this?
Now, I will. I think it was such a blessing for me. I didn't think of it at the time. But when I stopped affording private care and I became a public patient is when I realized how religious Kenya and Africa are, especially on matters, demons or witchcraft, which is related to mental health. I have worked with 40 to 50 families through their treatment in public facilities. I will tell you the majority of them come for care 10 to 30 years after the first known symptoms. And when you ask where they were at the church, they were at the mosque. I think in urban settings, it's more spiritual. In rural settings, for some, it's more traditional. For some, it's spiritual. And I think it's even worse on matters suicide. Yeah, because again, suicide is a very moral and religious issue. I'm currently a court petitioner to decriminalize suicide attempt in Kenya, something that we're doing with Professor Atwoli as well, and with the Kenya Psychiatric Association and the Kenya National Commission on Human Rights. And one of the things I've been doing is to get religious leaders to actually speak about suicide from the context of the Bible, the Quran, the Gita, because a psychiatrist will speak and people will be like, that those are, educated people matters. But when we have a sheikh and a pastor actually saying that we have let our people down, the church is the hope for the world. We need people to come and talk about these things because we have extreme, activities or cultures, beating dead bodies, for persons who've died by suicide, or they are buried in the forest, or buried without a cross, or buried at night, or not given burial rites by religious leaders. It's crazy. And the reality is, even if I have had suicidal ideation for the last 28 years, when a religious leader speaks, they first address the religious issue around mental health. And that's why I say, yes, it's good to have digital apps, but the reality is it will be for the middle class and the upper class, our Kenyans on Twitter and above, you know? But the people on the ground are very religious. And I know I said even in the last session, if we were to have, you know, religious leaders speaking into those apps or just speaking on radio, it is much more effective, yeah? One of the reasons why I get opportunities to speak in churches is because my father is a bishop. And so when I tell a religious leader, I am the daughter of a religious leader, I live with mental illness, and I need to speak with your people, they accept it. Sometimes I send religious leaders to media instead of myself going because they'll have a bigger impact. So I see a lot of disconnect, you know, between what the donors want and what we really feel is needed for the poor. Because at the end of the day, when I know that it is an app that you want, then I have to write that in the proposal, because you will say you don't support religious or political. Yet, as the National Task Force on Mental Health, we acknowledged that every 5 years, every 3 to 5 years, we have an increase in mental illness because of our toxic political environment. But the donors don't want to hear anything religious or political. So what impact are we really having? So yes, in Kenya and in Africa, it's necessary.
Thank you very much, and thank you, Femi. It's a pleasure to meet you. My name is Lukoya Tuli. I'm a professor of psychiatry and the dean at the Aga Khan University Medical College, East Africa. And I just want to pick up from what Charity has said. We work with her on a lot of initiatives. But when you asked everybody in the room to raise their hands if they are connected to an NCD or other, everybody did, all right? And then we're talking about advocacy. So I do a little bit of AI, and there's something called overfitting, so that the algorithm starts producing garbage. If you came into any board and asked, is there a person in an NCD-related board who is connected to NCDs, everybody will. So is there a risk then that we would start saying that everybody on that board is potentially an advocate for NCDs or for mental health if they are connected? And then is the goal of advocacy then to eliminate the need for advocates by having everybody empowered in that area, that then you do not need a person to sit there and say, I'm sitting here specifically as an advocate or a person with lived experience. So I think that is a conundrum I struggle with a little bit. So I'm paid to think, and I've been thinking about this quite a bit.
Thank you for sharing your angst. I'm not sure that is an actual question. I think that's a thought for us to think about, right?
Yes, absolutely.
Yeah, I appreciate that. I'm just going to let that sit with you, audience.
Yes, thank you very much. Thank you for the great panel. My name is Johanna Offer. I'm head of advocacy at Doctors of the World, Germany. And I would like to raise the issue of access to healthcare for NCDs, also for marginalized communities, and remind or tell everybody that even in Germany, refugees and asylum seekers only have access to healthcare in case of acute illness or pain. And it's very difficult for refugees and asylum seekers here to get access for healthcare for chronic diseases. And that is a very political issue because it's actually meant as diminishing pull factors, so-called pull factors of healthcare for refugees. And so I just wanted to bring this issue up and maybe ask you whether, providing full health coverage for everybody, not only citizens, is also an issue in your context.
This one's quite a specialist question, so I'm going to put it to Omar because I know that you will deal with young people who are also refugees. I'm going to ask everybody now to make questions brief, answers briefer, because I've got so many questions in the room and I'm going to try and get to all of them in the next 5 minutes. Omar, thank you.
No, very briefly, I think it's a very valid issue that you raised. I mean, the unfortunate thing is that it's politicized, right? I mean, everybody knows the right thing is for that person to have preventative care early on so that it doesn't become burden on the system, and it would probably cost more when they go to emergency care for the state, as opposed to getting primary care earlier on. But this is the world that we live, and we see it everywhere. And it's not only in developed countries here, but also in countries hosting refugees in Africa and others. This is a discrimination that refugees face, unfortunately.
Working? Yeah, perfect. Hello, my name is Raphael Cannon. I'm a French medical student and a youth advocate at this summit. So first, thank you all of you for your talk, really interesting words, and especially you, Madame Muchiri, for your work, because as a youth advocate, I really recognize myself and my generations into your words, nothing for us without us. My question is simple and a bit complex in the meantime. How to meaningfully, I say meaningfully, involve young people when it comes to human-centered universal health coverage?
Okay.
I'm going to do something unorthodox, which I never do, as you can tell. How to involve young people in making sure that there is nothing about us without us. So I'm going to ask you to introduce yourself, right?
I'm Haneen Audeh. I'm from NCD Child, representing NCD Child and also the World Diabetes Foundation in this conference. But I would like to... Yes, and I have a top-up question on that to the panel after. But
tag teaming questions.
Yes.
Very quickly.
Yes, so quickly I would say involving young people in advocacy programs and bringing their voices to the table everywhere at all times, from policy making down to implementation. And I think that investing in primary prevention and also having a life cycle approach. So we don't only look at young people or adolescents, but also look at all the missed opportunities that we are having interaction with the health system, with the educational system, with the agricultural system, and different intersections. So I think definitely all for having young youth voices at the table. And the question back to the panel is how are you doing that in your context, in your organizations? How much are you looking within this context of universal health coverage? How are we really bringing the youth voices to the table, and how much are we investing in a life cycle approach and in primary prevention so that we instill the behavior that rather than struggle in changing it later on? Thank you.
Bhagwan, in your advocacy and patient or people advocacy, any children, young people?
Thank you. Yeah, that's a great question. I think I would phrase the answer at two levels. At a national level, for at least my country or others, bring young people into politics. You decide your agenda at the national level. Maybe that's one right way to go. Good people are not in politics. Smart people, younger people are not in politics. But at a subnational or a concrete programmatic level, probably it again relates to the cause. When we talk about advocacy, nothing for us without us, meaning that a lot of young people suffer from bad behaviors, unhealthy lifestyles, disease itself, childhood, adolescence, NCDs. Again, that brings to the table of advocacy among the people living with sometimes disease, sometimes with the habits. So I think, again, that needs to be part of the agenda, that we need to sit with young people on defining the exact way of educating people, as well as taking the agenda at a national level in terms of health economy and the politics.
Excuse me for pushing you, because we have 2 minutes for this question. So it needs to be, young people need to be in the conversation, but at the moment in Nepal, they're not? Yes. They are?
Yes, yes.
Okay,
we actually, the advocacy is primarily done at this level by the younger people than the older people. That's the nature of the age and the inefficiency that they bring in. And you need to be part of the conversation at all policy levels.
Sure. Rahel, what's the youngest person who's working with you?
I think if we really look into it, this is an area where we really need to improve. Because even the way how we are providing for them the service might not be the same as the adults. Yeah, you know, but I haven't seen any NCD youth clinics, you know, in my country. So, you know, there is a lot that needs to be done as we are looking into the situation. But at the same time, we also need to understand, yeah, you know, like how far we can provide those services, because that's also another challenge. The economic burden that the country is facing is also sometimes, even if you wish to have those things, you may not have the ability to have it. But as far as possible, yeah, you know, youth will be part of it. People with disabilities or need, you know, special needs will be part and parcel. But are we, you know, to the ultimate where we need to be? You know, I still feel there is a lot.
More work to be done.
Absolutely.
All right. So, how fast 90 minutes goes. You made it so exciting and interesting, delegates. Thank you so much for being here. We are going to wrap up with the Type 1 Diabetes Program Director of Helmsley Charitable Trust, who is making her way to the lectern to outrageous applause, Gina Agiostradini.
First of all, I don't know how to follow this panel. I don't know what to say. First of all, I would like to thank you. Such a amazing panel. You came from Kenya, Nepal, Ethiopia, New York, I assume. Thank you. I really want to thank James, actually, who leads our global access portfolio at Helmsley, and he made this true, and Global Health Strategies for helping us, but also the World Health Summit for hosting us and give us an opportunity to talk about universal health coverage. Charity, thank you. Thank you for really make everything about people with NCDs. I think we all understand today that, and we believe, and we will fight to bring people with type 1, with NCDs to the front, to policy discussions. Bogdan, thank you for the PEN Plus. And if I ask now how many people know PEN Plus, it's going to be 100%. Rahel, you talked about the community health insurance. That's, I think, it's so interesting that Chai is thinking how it can make medicines, care, affordable for everyone. And Omar talking about UNICEF and the efforts with Lily to bring insulin to more than 60 countries. We're thinking about 40,000 children to have access to insulin. We all know that if you do not have insulin, these children will die. At Helmsley Charitable Trust, I represent the type 1 diabetes. But the reality is that we cannot think about diseases. We have to think about people. You have a woman who delivers a baby. Baby needs immunizations, needs vaccines. Children will have infections. Later, cardiovascular diseases, chronic diseases. We need a strong universal health coverage. I believe this is a right. We have to fight for a right for health. And I don't want to tell you and repeat anything that they said. I just want to thank you for being here. And all remember, please, that we need to fight for the right into health. It's something that without health, there is no life, there are no dreams. Thank you so much.
So I noticed there were more questions in the room than we actually answered. So I have generously left you 2 minutes to spend with your panel after I say thank you. This session is now over so that you can meet and greet your panelists. Thank you.